Thank you. Thanks, Professor Nima, and thanks all of you. Can you hear me and can you see the screen well?
Yes.
Yeah.
Okay. So I'm Bhushan Sabnis. I'm a knee surgeon based in Mumbai, and this is something which is slightly unusual, a lateral distal femoral osteotomy, and this is becoming rather more common in our armamentarium now that we are more confident and comfortable doing femoral osteotomies. So here is my take on LDFO as such. So we all heard this before. It's all about getting the alignment perfect. We all know this picture from Dror Pelle's book about how the MLDFA and MPT are the important angles around the knee to get your alignment perfect. And opening wedge HTO is a different procedure because you are protected by your fibular collateral ligament attachment, the proximal tibiofibular joint ligaments, which give a good support to your HTO on the other side. This doesn't work that well for a medial femoral osteotomy where there is not much of attachment at the hinge point. So there is no soft tissue support. As against that, for a LDFO, if you remember your anatomy of the medial side of the knee joint, there are those three tubercles, the gastroc tubercle, the adductor tubercle, and the medial epicondyle. And there's a big meshwork of ligament and soft tissue support on the medial side of the knee. So this works similar to what would happen on the lateral side of, for the HTO. That's why LDFO is slightly more stable in my opinion as compared to a medial DFO as such. Now, closing wedge has generally been a preferred surgery for femoral side, mainly because it's a very powerful surgery and it always heals. There's rarely a chance of having a non-union for a closing wedge DFO, but chances of hinge fracture are quite high. And all of us who have been doing DFOs, medial closing wedge DFO, have always always have skipped our heartbeat a few times every time you felt your assistant closing it too tight, or when you felt a sudden snap on the lateral side and you saw the hinge break. You most of the times are able to compensate with a good plate on the medial side, but there's always a worry that it might slip, and there's always a problem of collapse of the osteotomy or of displacement, which might lead to a worsening of the deformity as such. So when do we go for, why should we go for an opening wedge DFO? In this case, we're talking of lateral opening wedge DFO. We're talking of valgus arthritis, and that usually is generally associated with a lateral femoral condyle hypoplasia. If you recollect Professor Nima's talk, you remember that the proximal tibial varus angle between the epiphyseal line and the joint line, that there's narrowing on the medial side in medial compartment arthritis, and a similar analogy can be applied where the lateral side has loss of bone as compared to the medial side. So naturally thinking, the easiest way to compensate for this will be to open a wedge on the lateral side to compensate for this hypoplasia, and you can get a better alignment. So it does make sense doing a lateral opening wedge distal femoral osteotomy. Another key indication for doing a LDFO is whenever you're doing a derotation osteotomy. I do a fair number of derotation osteotomies, and this has been my preferred approach to distal femur. It's a pretty straightforward approach. Of course, we heard about Nagaraj talk about double osteotomy. Anytime a person has shortening on that side, I would hesitate to do a closing wedge osteotomy, and I would rather go for an opening wedge osteotomy. Of course, there are issues with skin problems and scars on the medial side, and you have to go for a lateral side. LDFO can also be done for patients who have lateral meniscal transplants or implants where you need to offload the lateral compartment, and also for repeat failures of MCL repairs or reconstructions where you need to offload the lateral compartment. It can be a medial closing wedge or a lateral opening wedge, but whenever you're doing a MCL repair, there's already a lot of metal work on the medial side, so it's better to go for the lateral DFO as such. So this is the same, this is the image, the key image that you always want to see, where your hinge is intact, you opened it nicely on the lateral side, and your Mikulicz point is coming towards the 50% mark. We normally aim for about 47% when you're trying to offload the lateral compartment. A couple of papers which are really impressive. This is a very good paper about lateral opening wedge technique, which talks in details about the procedural techniques as such. Rob Laprade has given a very good paper about the effects of a lateral opening wedge DFO, and it's really a good paper. And another paper from I think Mayo Clinic, which talks in great details about LDFO as a surgery in arthroscopy techniques. It's a good video to see as well. So those of you who are interested, you can quickly have a look. So we all heard about how to plan the surgery, and you can use a Miniachi technique, or you can use a simple technique where you can join the mechanical axis of femur and tibia and find the angle of deformity and extrapolate that from the hinge point to decide the correction that you want. Most of us now have moved to either a trauma CAD planning or osteomaster planning, where we digitally plan the osteotomy. And if you can see here, this is about 7mm opening osteotomy on the lateral side, and that will get the leg back into a proper alignment. So important to have a proper planning done. But one more thing is that you can dial the osteotomy on table. So if you're not happy with your planning, if you made a mistake in your planning, unlike a closing wedge osteotomy where there's not much of room to play with, for an opening wedge osteotomy, you can easily increase or reduce the correction that you're achieving to get the perfect alignment. The procedure is fairly simple. The lateral distal femur is sitting in front of you. All you need to do is just make a cut in the skin. Now, I normally don't cut the iliotibial band. I like to go anterior to the iliotibial band. This was a trick taught to me by Feng Hua from Beijing when I was visiting him, God bless his soul. And it just makes life so easy. You don't have to struggle with your ITB. Just bend the knee slightly and the ITB falls posteriorly, and you have the whole lateral distal femur in front of you. Dissect the posterior part of the periosteum very slowly and very carefully, because the neurovascular band is sitting very close to the lateral aspect, and make sure that you put a Hohmann or a big retractor underneath to protect them. Then you pass a couple of parallel guide wires as you would normally do, followed by a standard osteotomy. Now the hinge point of the osteotomy is on the medial side, about 5 to 10 millimeters from the cortex. And generally, because of the strong ligamentous and soft tissue network on the medial side, it's a pretty stable osteotomy in my opinion. You pass your osteotomes to gradually open it. I always do a biplanar osteotomy. It works in two ways. One is you're not violating the patellofemoral joint, and second, you can go way down to get a good metaphyseal bone and not be in a diaphyseal femur as such. So first pass a guide wire. As you see, that's the hinge point that is marked. Then you pass your saw on top of the guide wire, and then you open it slowly in a standard way as you would do in your HTO. You can indeed pass a hinge pin. I sometimes put a staple on the medial side if I'm worried about it. I have thought, or I have toyed with the idea of putting a Herbert kind of screw on the medial side, but fortunately haven't required to do it yet. But I would not be averse from putting a fixation on the medial side if I'm worried about my hinge point as such. So that's your DFO peak plate, lateral DFO peak plate, which works brilliantly. Now you need to put the plate on the bone before you decide on the osteotomy. The plate is designed with Caucasian people in mind, so it's in petite Indian patients. You might need to alter the level of osteotomy, as you can see in this patient, where the osteotomy has been proximalized slightly to compensate for the plate geometry as such. But a peak plate gives a very good fixation, and it gives you a good view of how the consolidation is happening with time, because it's not blocking your view. Those of you who are keen-eyed can actually see a hinge fracture, but funnily enough, 2 weeks of non-weight bearing, it went on to heal perfectly fine. A few tips and tricks. It's a very easy approach from the lateral side. Just go anterior to the ITB. Neurovascular bundle, as I said, it's not neuromuscular, neurovascular, sorry about the typo, is more lateral. So be very careful in your lateral dissection. It's just sitting very close to the bone there, so release it properly. Always do biplanar osteotomy, because you need to have a good hold on the femur. If you do a uniplanar osteotomy, you get a very bad unstable femur, which will need a fixator for sure. I generally use bone graft for any open osteotomies, but that's entirely up to you. The femur tends to heal usually as long as you're cooling down your saw and you're not causing thermal necrosis. There's not much a matter of slope, so you can do a rectangular opening, and it's important to have an angle stable secure fixation, which can be achieved with your Arthrex LDFO plate. That's a small optic video by Arthrex guys, and you can indeed see a standard procedure as you would normally do in your HTO. Just extrapolate that to your femoral side, do a standard bipolar osteotomy, use your osteotomes as standard to open the osteotomy very gently. You can stack your osteotomes. Always be a bit slow on the femur. Femur is a very strong bone as compared to the tibia. Once you open the osteotomy to a desired level, you put a wedge and a laminar spreader to hold the position, and then you place your LDFO plate and fix it in a standard way. You may or may not want to use this sheath on top. You get 4 screws distally and 4 screws proximally. I normally use a golden screw to compress the plate, but it's not imperative. I always make a conscious effort to change this screw to a locking screw. I feel there is no role for a cortical screw in the locking system. So all locking screws at the end, and you get a brilliant fixation as such. Now, why use a LDFO peak plate? The main advantage of this plate is the 12 degrees of variation that you get in your screw alignment. So if you want to push the plate more distally, you can align the screws in such a way that they're away from the osteotomy and getting the maximum purchase in the bone. If you are very brave and you're doing a ligament reconstruction, along with this, you can alter the screws geometry in such a way that your tunnels won't come into the screw trajectory. And it just gives a very good stable fixation in general. Now, if I just go back, you can see the position of the plate. Now, if we use the titanium plate, you see how close to the joint the lateral plate is. And unfortunately, that does cause a lot of irritation of the iliotibial band as it crosses from crosses along the trajectory of my mouse here. So you will need this plate to be removed very often. As against that, an LDFO plate generally can stay in forever without any issues as such. A few examples. So as Clement said, you can use a medial sided plate of the opposite side from synthesis kit for the for your lateral fixation. The only worry is I don't know if it's covered by insurance if there anything happens with failure of the plate, because it's only designed for a medial side. Fortunately, we don't have that much of worry in India about it, but that probably Professor Nima can tell us about it, about the seriousness about this. So that's the opening that you have achieved on a lateral side. A couple of examples, the same one. Now, this patient was so happy with her LDFO, she refused to have another scanogram, so I had to extrapolate that to actually see how it looks now. So it gives a really good fixation and results as such. Now I do a bit of derotation work as well, and this is my standard approach for the lateral side. The only difference is my osteotomy is more parallel to the joint as compared to an oblique osteotomy that you would make. So I do this normal biplanar cut, and I use that double biplane cut in the osteotomy to open it more on the valgus as compared to the medial side. So I'm actually doing an opening wedge osteotomy on the lateral side along with derotation at the same time and fixing it with the plate on top. So it works quite well to have this approach. These are the basic steps for a varization plus derotation osteotomy, DFO for patellar instability as such. And that's just how it looks when you're derotating the femur. Along with changing the alignment as such. Okay. So I think LDFO is a very powerful surgery, and it gives a really good fixation, and it is a good tool in your armamentarium to try and incorporate in your normal day-to-day practice. Thank you.